We're going to talk about interstitial fluid shifts, and that's going to include an overview of hydrostatic pressure, oncotic pressure, and increased capillary permeability. The first thing we need to think about is that the capillaries are comprised of endothelium. Endothelium is very important for maintaining homeostasis. One of its jobs is to regulate what goes in and out of this semi-permeable capillary membrane. It does this through processes like osmosis, diffusion, and filtration. We're going to talk a little bit more about filtration. One of the pressures we're going to talk about is hydrostatic pressure. Hydrostatic pressure is created by fluid. We have fluid that's inside of our blood vessels and our capillaries, which we call intravascular fluid. We have fluid inside the cell, our intracellular fluid, and then we have fluid that's surrounding the cells outside of the capillaries. It's called interstitial fluid. So these fluids are creating pressure. The hydrostatic pressure that's inside the capillaries is pushing this way to push fluid out of the capillaries, and then we have a smaller amount of fluid that's exerting a smaller amount of pressure to push back into the capillaries. These two need to stay in balance to keep the right amount of fluid on both sides of the membrane here. So, what could increase the amount of pressure that is being created? One thing is we can increase the amount of fluid, and another is to increase the amount of pressure. So if you think about the fluid inside of the blood vessel, then if we increase the amount of it, that would exert more pressure on the capillary walls to push more fluid out, or if that fluid was under more pressure. So if you think about it, it's coming from the left side of the heart, it's being pushed by the cardiac output. The more pressure that's under, the higher the blood pressure, the more pressure would be exerted on the capillary walls. So if we think about a condition that could increase the amount of fluid in your capillaries, like congestive heart failure or renal failure, these would increase the pressure and you would get more fluid pushed out here into the interstitial space. So if I was to assess this patient, what would I find? I would find edema. Okay, so then what would I need to do to treat that? The problem is that I got too much fluid in the intravascular space, which created too much hydrostatic pressure and is pushing fluid out. So I would treat them with things like fluid restrictions, diuretics. If the problem was kidney injury, I might use dialysis, but all of these are going to work to try to decrease the amount of volume that's in the intravascular space. So when we get that volume decreased, then this fluid out here exerts pressure to push that fluid back in, and we can increase the pressure for the interstitial hydrostatic pressure by elevating their legs. So if we elevated it, gravity would increase the pressure pushing on the capillaries and push more fluid back into the vascular space where it belongs. Another example for hydrostatic pressure is to think about a water hose. So if you think of the water hose as the capillary and the holes as it being a semi-permeable membrane, then if you barely turned on this water through the water hose, it would be just trickling through the water hose and nothing would squirt out of the hole. That would represent a low hydrostatic pressure. But if I were to crank that knob wide open and I had lots of water under a high pressure flowing through this hose, then it would start squirting out of the hole. That would represent a high hydrostatic pressure, and the fluid that would be squirting out would be going in the interstitial space and would represent edema. Okay, so let's think a little bit more about this fluid that is going around the body. The blood's coming from the left side of the heart, going through the arteries. Then it goes through the capillaries. We have cells out here. And then it goes back into the veins, heads back to the right side of the heart. So as this fluid is going around the body, which side do you think would have a higher hydrostatic pressure, the arterial side or the venous side? And it would be the arterial side because the left side of the heart is pumping, the blood pressure is higher in the arteries, so there would be more hydrostatic pressure over on the arterial side. So as the blood is coming through the capillaries on the arterial side, there's going to be more hydrostatic pressure, more fluid's going to be being pushed out, and that's going to take nutrients, oxygen, things like that to the cells, and then going to collect the waste products, the carbon dioxide, and then as the hydrostatic pressure decreases on the venous side, and we also have oncotic pressure here pulling that fluid back in and then going to back into the veins and going back up to the right side of the heart. So that's a normal process that's always occurring. Fluids being pushed out with hydrostatic pressure, pulled back in with oncotic pressure. And we're going to talk about oncotic pressure here in just a minute. But if either one of these get out of balance, then we can get too much fluid collecting out here in the interstitial space. So in the example that we just talked about, we have someone who, for example, we'll just say renal failure. They have too much volume in their capillaries, so they've got a lot being pushed out here, and it's more than can be reabsorbed into the venous side, so they start to develop edema. Okay, so now let's talk about that pressure that's pulling that fluid back in, oncotic pressure. What creates that pressure? So we still have the fluid, like we always do. We have some interstitial fluid, we have some intravascular fluid. So we've got all these fluids we've been talking about, right? But what actually creates oncotic pressure are proteins. And the biggest and most significant protein is called albumin. So we have all this albumin in our vascular space, or in our capillaries. There is also some albumin in the interstitial. There are some proteins out here, but they are not as big, not as many in the interstitial. So we have more in the intravascular that's pulling that fluid that's come out with the hydrostatic pressure back in to the capillaries. So the problem comes in when you have a patient that does not have enough albumin for some reason. So maybe they're malnourished, or they have liver failure and their liver is not synthesizing albumin, but for whatever reason they do not have enough albumin. That's going to decrease their ability to pull fluid back into the vascular space. So then we start to get fluid building up all out in the interstitial space. So when I went to go to assess this patient, what are they going to look like? Once again, from the outside, they're going to have edema, right? But I have to be thinking about what's causing this edema. So in the case of decreased oncotic pressure, what does that tell us about our vascular space? We have to think about it separately, because the reason there's edema is that it's been lost out of the vascular space and the patient does not have the ability to pull that back into their capillaries. So they can actually develop a fluid volume deficit. So I would need to assess their vascular space separately. I would think about their vital signs. For example, maybe I came in and their blood pressure was 90/60, their heart rate was 120, and last night they had 100 milliliters of urine output for the whole 12 hours. Then, okay, they may have some intravascular fluid volume deficit. If I were to just walk in and say, oh, they have edema, I need to give them a diuretic, then where is the diuretic taking the fluid from? It's taking it from the vascular space, because it is taking it from the kidneys, from the glomerulus capillaries that are in the kidneys. So it's taking fluid directly from the vascular space, which is already low. So all of these are then going to get worse if I do that. So what would I need to do instead? They need intravascular fluid volume replacement. So if I were to give a crystalloid IV fluid, what type would I give? I would want to give something that's going to stay in the vascular space, so I would want to give an isotonic fluid. Now, a lot of people might say, well, what about a hypertonic? Because that'll pull more fluid in. But a hypertonic is going to affect the osmolality of the extravascular fluid, so all this fluid in the interstitial and intravascular. So it is going to pull fluid from the cells. We're not wanting to pull fluid from the cells, we're wanting to pull it from the interstitial space back into the intravascular. So we could do isotonic just to temporarily fix the problem of fluid volume deficit in the intravascular space, or we could give them a colloid to actually try to increase the oncotic pressure and pull it back into from the interstitial into the intravascular. So if I were to give them albumin, for example, that would increase the oncotic pressure and pull fluid back into the vascular space. So you might see an order that says something like, give albumin, wait 30 minutes, and then give Lasix. The reason you're doing that is you're giving albumin to increase the albumin in the capillaries, increase the oncotic pressure. That's going to pull fluid back in from the interstitial, and then wait 30 minutes to give that time to happen, and then give them the diuretic to get the extra fluid that you've just pulled in from the interstitial out of the intravascular space. The next thing we want to talk about is increased capillary permeability. So remember how we talked about the endothelium is responsible for controlling how permeable the membrane is, or what goes in and out of the capillary membrane. So some things can increase that capillary permeability. One of those things is inflammatory mediators. Pro-inflammatory mediators might be things like histamines or bradykinin, but all of these pro-inflammatory mediators are going to cause vasodilation and increase capillary permeability. So this occurs at the local area, wherever the problem or the injury is. You're going to see these blood vessels are going to dilate and they're going to become more leaky. So why would we want that to happen? If we have an injury out here and these vessels get more leaky, then in order to fix that injury, we bring more blood to the area. So we get more blood in here, and then we get the ability to leak out not only the plasma, but also like cells like neutrophils, macrophages, whatever is needed for the body to go out here and repair this injury. So this is a good thing. It happens at the local level to repair an injury. When you think about your symptoms of an inflammatory response, I like to think about turning my ankle. The reason is because it's a reminder that not all inflammatory responses are caused by an infection. It could be any injury to a cell. So yes, an infection can cause it, but any injury could. So if you turned your ankle, what would it look like? You would expect to see that it is red, warm, and swollen. What's causing these things? Well, you have vasodilation occurring, so you have way more blood down in this area. So, and you have plasma leaking out, so that's going to make all that extra blood's going to make it feel very warm and look red. And then because of the leakiness or the increased permeability, you have all this extra fluid out in the interstitial that's going to result in swelling. Again, this is a normal process when you have tissue or cells that are in trouble. It's very applicable to every body system. If you're thinking about pneumonia, for example, then we have an inflammatory process going on in the lungs, and that causes all this fluid and inflammatory response, which is going to decrease gas exchange. If you think about a person who has a traumatic brain injury and they have cells that are injured, they have an inflammatory process occurring, which is going to cause fluid leakage, which could cause cerebral edema and increase their intracranial pressure. So any body system, this is applicable. The normal thing is for this to be kept at the local level where the injury occurred. The endothelium has checks and balances to keep the inflammatory response at that local level. But we get a bigger problem when the checks and balances are escaped and these inflammatory mediators get all over the body. That would be systemic, or systemic inflammatory response syndrome, or SIRS. SIRS, when caused by an infection, is known as sepsis. So with this syndrome, we now have all over the body vasodilation and increased capillary permeability. Of course, the more inflammatory mediators, the worse the syndrome is going to be. But with vasodilation, we're going to have lower blood pressure, lower cardiac output. That means less perfusion to the organs. We get increased capillary permeability all over the body, so fluid leaking out everywhere. We're going to get generalized edema. So once again, we have a patient with edema, but we have to think again about their intravascular space. So if the fluid's leaking out and they're very vasodilated, we're looking again at a fluid volume deficit that we may need to correct for the intravascular space. But when we're thinking about treating this, what's causing it. In this case, it's the inflammatory response. That can be more difficult in some cases than others to treat, but like in the case of sepsis, we know that it's an infection causing it. So in order to stop this from happening, we would have to give them the right antibiotics, get rid of the infection, and then stop this inflammatory response. So we've talked about 3 different things that could cause interstitial fluid shifts, or more fluid in the interstitial space. That would be increased hydrostatic pressure, decreased oncotic pressure, and increased capillary permeability. And with each of these, we need to be thinking about what's causing it and what's the status of the intravascular space, and then how do I treat it. So one example we can use for that is thinking about pulmonary edema. Generally, when we think about pulmonary edema, we think about cardiogenic or hydrostatic pulmonary edema. That's when something is causing the left ventricle, or either of the ventricles, but we'll talk about the left ventricle, not to work as well. The left ventricle should be pumping fluid out to the body, but if something happens and we have a decreased cardiac output for some reason, then that is going to start backing up, and it'll back up into the blood will back up into the left atrium. It'll continue to back up into the pulmonary veins. So our heart is supposed to be pumping the blood out to the body, but if that is not happening effectively, then we start getting a backup of blood through the pulmonary vein and into the pulmonary vasculature. So all through the pulmonary vasculature, start to get veins that are very swollen. If you saw this on a chest x-ray, it might say pulmonary vascular congestion. So we get all this extra fluid in the capillaries. That's going to increase the hydrostatic pressure in the capillaries, and then that's going to cause fluid to be pushed out. So that's usually plasma that gets pushed out. I don't have a good plasma color, so I'm going to use yellow. But we get plasma pushed out in the pulmonary interstitial space, and it can push on the alveolar membrane, and we get plasma in the alveoli as well. So that gives us the symptoms of pulmonary edema. We may have crackles, we have poor gas exchange. So what would we do to treat this patient? Well, we would need to get rid of this hydrostatic pressure, right? So we need to decrease the amount of fluid. We could do that with diuretics. We could hopefully increase their cardiac output and try to get rid of all this extra fluid, and then the fluid that's in the alveoli will hopefully go back into the capillaries and fix their gas exchange problem by decreasing the hydrostatic pressure in the capillaries. Now, another type of pulmonary edema is a non-hydrostatic or non-cardiogenic pulmonary edema. This would be a pulmonary edema that could be caused by something like that inflammatory response that we just talked about. So the capillaries get leaky, and the fluid just starts leaking out of them. This can also affect the alveolar membrane, and then we get fluid leaking into the alveoli. This can be bad enough that we get proteins leaking out as well. So if this is high protein fluid, remember proteins pull fluid towards them, so that's going to make this even worse, having more fluid in here. Again, we have the symptoms of pulmonary edema. We have crackles, we have decreased gas exchange, but we have a different cause. So the treatment is going to be different. This time, diuretics are not going to be a primary treatment, because that's not the problem here with the increased hydrostatic pressure. This is because the capillaries are leaking from the inflammatory response. So we would have to support our patient's gas exchange the best we can, but ultimately we have to knock out whatever's causing that inflammatory response to stop this process from occurring, which is way more difficult than just giving a diuretic. So you have to think about what's going on with my patient, why are they having these fluid shifts, because the cause is going to make the treatment different. So I hope this has helped overview of interstitial fluid shift.